as per our constitution, as per the fourth schedule, of course, we do the policy. The county governments do the implementation, and therefore family planning is part of their service delivery. Family planning products is part of the national strategic commodity.
Yes.
With the sense that, of course, somebody in Turkana, if given an opportunity, I mean, if he or she wanted to buy implant,
Yes.
where will she get? I mean, it's not available. I mean, so as part of pool procurement and making sure that we get these services, I mean, we get these products to the last mile.
Yes.
And therefore, that is why that decision was made to make family planning products a national commodity.
Access to safe, voluntary family planning is a human right. Family planning is central to gender equality and women's empowerment, and it is a key factor in reducing poverty. Yet many women in Kenya who want to avoid pregnancy are not using safe and effective family planning methods. In this special series, in partnership with FieldMaid Kenya and UNFPA, we focus on family planning in Kenya.
Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making it simple and easy for you to understand. I'm your host, Dr. Diana Wangari Gitao. And in studio with us, we have important guests, and we'll be talking about an even more important conversation. We've been having discussions around family planning in Kenya. We've had policymakers in studio. We've had people working in communities trying to explain and show us the need for family planning. So the topic today is the economic case of family planning. Sounds big, but you'll see when we get going why family planning is important. I'll let the guests introduce themselves and we'll get going. Dr. Serem, we'll start with you.
Thank you very much for having me. And my name is Dr. Serem Edward. I'm the head of the Division of Reproductive Maternal Health, where I am in charge of maternal neonatal health, family planning, and sexual reproductive health for the adolescents and the young. At the Minister of Health. Thank you.
Absolutely. We have government in studio with us, folks. Government in studio. Dr. Macharia, introduce yourself.
Sure, and thank you for having me here. My name is Dr. Sheila Macharia, and I'm a wife, a mother of 2 boys. And currently I work for an organization called FP 2030. It's a global organization. I'm running the regional hub, which is here in Nairobi, and our work is vast and different.
Absolutely, and we'll get into that quite soon. I mean, Dr. Serem, the department you head is a very important department, reproductive health, maternal health. Those are very key issues, right? And maybe first give us an understanding of what the department looks like and where family planning falls into that, right? Why is it? Give us an overview of the department and your work day to day.
Yes. In the department, and I would like to call it, thank you very much, and I would like to call it a division.
Yes.
Because that is the structural organization of the
I
Minister
apologize.
No problem. The structure of the Minister of
Yes.
Health. So being the head of the division, Therefore, I manage the programs, as I've told you, maternal neonatal, where we deal with issues. We want to make sure that in the maternal family planning and adolescents, young people, sexual reproductive health, then we deal with. One is policy review development, guidelines development, standard development, technical assistance to counties, resource mobilization, in the country, data analysis and research. So, in all this, therefore, because now we are talking about family planning. So, on this, therefore, in my docket, I squarely, therefore, be in charge of policy development for family planning. What is it that we want our country to look like in terms of family planning?
Yes.
Developing the guidelines for trainings, training curriculums, and programs, operational programs, to make sure that the country gets services in matters of family planning. Because as we talk about family planning, we are talking about several options. Because family planning is an option. It is not that you give family planning to people on prescription. It's a decision.
Yes.
People are given to make the choice. Do they want family planning or not?
Yes.
And for your information, therefore, I want to tell you categorically from this surveys which have been done, the last KDHS report, the demand for family planning is high. That people want family planning choices.
Yes.
And we have several options. Injectables, tablets, insertions, and implants.
Absolutely.
So with that, therefore, is that we I mean, the issue here as a division, we want to make a country where women and the Kenyan population enjoy their rights of being the highest attainable health standards,
Yes.
including reproductive health,
Absolutely.
where family planning
Falls
comes
under.
in. Thank you.
Absolutely. I mean, heavy stuff, Dr. Macharia. Heavy stuff.
That's why I'm coughing.
It's like the pressure of the Division of Reproductive Health.
Yes.
I don't know. FP 2030, what is it? How does it work? Maybe give us a background. Yeah.
All right.
Yeah.
So because family planning is a global concern, not just in our country, FP 2030 is a global partnership or an international network, and it's made up of development partners, country governments, NGOs, civil society organizations, and private sector. This is a partnership of people who have a vision, and the vision is that everywhere in the world, families, women, and young ladies should have the right to get information about family planning services, to decide if and when they want to have children, and therefore to be able to live healthy lives and to participate in their country's development. So that's the broad vision.
Yes.
And so our regional office, which is here in Nairobi, oversees work in 23 countries. Basically what we do is that we go to the country and say, we know you already have plans for family planning programs, as Dr. Serem said. And what we're asking you to do is to take your country plans, which are in different policies, summarize them in one document, make it a commitment which your minister signs, and Kenya has done that. And then with that, call the people who help to provide those services. So there will be governments like counties here who are providing the services. There are NGOs who are funding activities in the counties, training of health workers, or people who go around and see services are being given, or people who help with distribution of commodities. So bring all those NGOs, bring all those donors together and say, collectively, this is our plan. Can we monitor together so that we can see family planning advancing? The reason this partnership was formed was because in 2012, the world realized that in order to enhance the health of women, you needed to pay attention not just to the care they get in pregnancy, but also the care they get after pregnancy. And one of the things women want to do after pregnancy is to space their children. And so because that wasn't happening very well, in 2012 in London, a big meeting was held. Kenya was represented by the Minister for Planning, who was Honorable Oparanya. And government leaders went there. It was led by the British government, the US government, and others. And government leaders came and said, collectively as the world, we're going to achieve Sustainable Development Goal 3 and 5, which were to do with health. And the Secretary General of the UN had released a big global strategy for women and children, which included getting family planning everywhere. So all these governments and donor partners got together and said, you know what, for the next, for between 2012 and 2020, we'll have a partnership. We'll call it FP 2020. And we are going to have 160 additional women using contraception or family planning services. And so, or 120 women. And we're going to focus on the countries with the highest need, 69. Most of those countries were in our continent and in Asia. And by 2020, they had not reached the goal. They had reached half of that goal. So instead of 120 million, 60 million. And so they said, maybe one of the reasons why this didn't work so well was that the partnership, the office was in Washington, D.C.
Yes.
And we are speaking to people as the global north to the global south. So why don't we have offices in West Africa, to cover that part of the world, East and Southern Africa, Asia and Pacific, Latin America and Caribbean, and then North America and European hub, and have those commitments made there with people who understand the context of the countries around them, the cultures, the beliefs, how the health program works, who can get relationships with, like Dr. Serem, because we are building relationships with senior people like Dr. Serem in all the countries. And so FP 2030, therefore, was brought there, the next partnership. This partnership is not limited to certain countries, and it doesn't have a goal of reaching how many. No, it is just open. It's just supporting us to reach the Sustainable Development Goals. And, basically at the end of the day, it's looking at the health of women and girls.
Yeah.
That's what it's about.
Well, it's important. I like the fact that, number one, you mention a commitment, right?
Yes.
Because it's very easy sometimes to get lost in the discussions, the theories, right?
Yes.
We want to do this, we want to go there and whatnot, right? And fundamentally, we all want to do good, right? We want, to improve the lives of families, etc., etc., right? But until there's a commitment and saying, you put pen to paper and say, okay, not only are we following this, we're also willing to say, add on to this and this and this. Then at least there's something you can even measure and say, okay, you track, right?
Exactly.
And the second element, I like being closer to home. Because for most of this partnership, it's always viewed, as you said, sometimes it's far removed from Kenya. If people met in London and it remains in London, it becomes a London thing.
That's right.
But if I can call you up, right, Dr. Macharia, you can call Dr. Serem, it starts becoming more relatable. And slowly, it might not be the ownership that most people want, that it's this ownership today, but we're starting process by process.
That's right. That's
step by step. Dr. Serem, I hear Dr. Macharia saying Kenya, we're leadership, we have committed. The National Family Planning Program has been in Kenya for a while, right? And we were one of the leaders who are able to say within this region that we're actually taking this on, right? Would you say from where you sit, and you have the advantage of having access to a lot of data, right, that necessarily people might not see on a day-to-day basis, would you say there's a return, there's positive impact? When you review the data, right, the National Family Planning Program in Kenya, has it had the desired effect that was envisioned at the beginning? And how long, by the way, has the program been ongoing? Yeah.
The program, thank you very much for that. The program Family Planning was actually, the former president, when he was the Minister for Health, former President Kibaki, he was one of the champions. And we will actually give a lot of attributes to him because he actually initiated the family planning program here in Kenya. And we will say that from the data which we already have, since then, very many years ago, we are talking about the attributes and the impacts of family planning programs in our country. One is, fertility rate. We have moved from 8 children per woman in the early 80s to now about 3.
Absolutely.
As of now.
My grandma had, I think, 16.
So, and with that, also with the data which you already have, the spacing of children has brought in the issues of reducing maternal mortality and even child mortality, because the woman has the potential and capability to take care of the child and be in a position to recover. And we are advising and we emphasize that let a woman at least have 2 years to 3 years of recovery after delivery.
Yes.
And we are seeing a positive impact in the sense that the modern contraceptive prevalence, ile watu wanawake ambao wanatumia, the women who are using modern contraceptive options, which are several, there are about 5 or 6 in our country. We are seeing a good trend. We are now at 57%.
Yes.
As a country, we aim to have about 64% by 2030.
Yes.
With this one, therefore, what are we saying is that we make women we have been in a position, therefore, to the data which we have. I mean, the availability of family planning products has been in a position to afford 4.5 million unintended pregnancies.
4.5
million unintended pregnancies. While those ones who are not interested in pregnancy, because sexuality is a different issue. We have been in a position to afford about 600,000 unsafe abortions.
600,000 unsafe abortions
Through family planning. And the provision of family products. And I will tell you, about 4 million women in our country are using family planning products. We have been, therefore, with sustainable, progressive use of family planning products, we have been in a position to avert about 6,000 maternal deaths arising from if family planning products were not available.
Yes.
All these, if you convert into economic scales,
Yes.
when you talk about maternal mortality, what does it mean? Therefore, family planning products, when used, therefore, as economic gains for the girls, for the youths to be in school and to be in colleges and to be productive and to delay getting children. And for the married women, also to be productive and be in a position to make their rights and to when they can have children.
Absolutely.
Yes.
I mean, it's, you hear conversations, and I'd see it's a lot of myths and misconceptions around family planning, right? You always hear around, it's either a foreign agenda, it is ensuring that family planning and contraceptives is around being promiscuous. Then yet people forget that the impact, and even maybe not the impact, the use of it, is that girl who, number one, maybe it's not because she's been promiscuous, she has an unintended pregnancy, as you're saying, right? We have seen cases of girls as young as 13 just because of their social economic circumstances falling pregnant, right? A girl who's 13, it's not the time to have a child, right? So there are elements, there are cases, and there are cases that you don't want to be pregnant. Maybe because of just life in itself. It's also you're married, for example, and you want to be able to take care of your children, right? And I'm saying that because some of the feedback we've had with this family planning conversation has always been that it's very aggressive, it's very anti-family planning, right? Some of the comments we receive, and I always find that it's important to remind people, it is the 600,000 at unsafe abortions, right? It is the numbers you're quoting to us to say that it is not about promiscuity. It is not that girls are out here, and it's not just a girl's conversation, it's also a men's conversation, right? It's not about all this, what I would call external conversations. It's about real lives, right? And an impact to women, families, and the economy at large, right? Now, I have to Dr. Serem, before I go back to Dr. Macharia, Kenya is a devolved, healthcare is devolved, right? And because of that, that means that there is certain powers that are allocated to the counties, right? And sometimes it almost feels like the conversation on family planning is a very national conversation, which there's no problem. But then I'd want to understand, and I think our listeners would also want to understand, that where do the counties play in this, right? So that if I am in County X, which is located far removed from the big city, right? I know I can go and hold my governor accountable. I can go ask, because they are empowered enough to actually own family planning, right? Is that the case? Where do the counties fall in all this conversation on family planning?
Thank you very much, Dr. Diana. And as I've mentioned, that our work at the national government is to provide policy directions, give guidelines, and provide standards, technical assistance, and offer training and mentorship in matters of family planning. And we do that one traditionally. We do that.
Yes.
And I will tell you that the guidelines which we have is the trainings. So the
Robust guidelines.
Standardization of the family planning trainings is to the point.
Yes.
So therefore, as I come back to your question, therefore is, as per our constitution, as per the 4th schedule, of course, we do the policy. The county governments do the implementation, and therefore family planning is part of their service delivery issues.
Okay.
Therefore, but at the same time, why family planning products is part of the national strategic commodity?
Yes.
With the sense that, of course, somebody in Turkana, if given an opportunity, I mean, if he or she wanted to buy implant,
Yes.
where will she get? I mean, it's not available. I mean, so as part of pool procurement and making sure that we get these services, I mean, we get these products to the last mile.
Yes.
Then therefore, that is why that decision was made to make family planning products a national commodity.
Yeah.
And that is we do religiously with our partners like Sheila and others
Yes.
to make sure that we centrally purchase, get it to KEMSA and distribute it to the last mile,
Yes.
both public and private.
Absolutely.
And when we do focusing on quantification, we look at the whole population.
Yes.
How many women require family planning? And that becomes our rationale as to what is the figure which you are giving.
Absolutely.
And therefore the duties of the counties is therefore to make sure that family planning services are available. That we will facilitate the training of the personnel, but to make sure that the personnel are trained to offer that service up to the last mile. That is what we would like the counties to do.
Yes.
Because at the end of the day, we want to make sure that these services are available to women and girls. At the same time, when you mention about, when I mentioned about the issues of unsafe abortion and unintended pregnancies, yes. But I also want to bring to your limelight and to this discussion that we are doing this cognizant of our laws, that girls are supposed to be in school.
Yes.
And what we are doing, therefore, is what we are saying is that there is the Children's Act, which is very clear that a girl, who is supposed to use contraceptives, who is less than 18 years, has to get the consent of the parent. That one is in force.
Yes.
And I want to be very categorical about that.
I hear you.
Yes, because in that issue, a girl is a young child or an adolescent.
Yes.
That person, that human being is supposed to be either in school or in college or in all those.
Yes.
However, we know we don't have 100% taking up of that law.
Yeah.
But we do advocate a lot of what we call social behavioral change, and more so giving information to girls.
Yes.
And we have, as a ministry, we've come up with a booklet called Understanding Adolescence, which is synonymous to what other countries call it comprehensive sexual education.
Absolutely.
Therefore, we are rolling this one in schools because we want to make sure that boys and girls get information concerning their development. What is it that changes which comes off during the adolescence? What is it that they should expect? And what is it that they should not do? What is it that they should avoid? As part of primary prevention of unintended. Because there we are now talking about the 3 threats.
Yes.
Yes. As we talk about unintended pregnancies, we also want to teach them about HIV, and we want to do, all those kind of bad things.
Yes.
So therefore, that is our aim.
Yes.
Social behavioral change and giving the youth information concerning their bodies, concerning sexual reproductive health.
Absolutely. I mean,
and to finish it up.
Yeah.
Therefore, as we are doing that also, we want also to digitalize.
Yes.
Yes, we are coming up with the digital platforms to make sure that the population, we are in a digital world, that they can access this information.
Absolutely.
Yes, thank you very much.
Absolutely. I mean, Dr. Macharia, sitting here, in fact, hearing Dr. Serem, and it was important that he gives us, from a government perspective, what they are doing from end to end. It seems like it's not just about having the commodity available, there are systems, there's training, there's all this, right? But we know that, number one, globally, the economy, there's a lot of changes that are happening, right? There's narrowing of fiscal space, right? And Kenya being one of the partners, right? Under FP 2030, who has committed, right? You cannot avoid the fact that there will be need for innovation. We'll need to adapt, right? The program has been running, right? There's goodwill, it sounds like, right? But given the competing priorities, everything else that's happening globally, they will need to find a way to keep this program running, right? Mm-hmm. What would you say, and this is a two-in-one question, is number one, how could, say, governments adapt, right, in terms of whether it's innovative financing, different approach, so that they sustain, the programs can go on, right? And I'd also, the second element of that is then what actively would you say from an FP 2030 perspective is the support that's being offered, right, for that adoption, so that it's not we are letting you go, figure it out from your end, right? Mm. How should they adapt and what support is being given?
Mm. Allow me to start from my own experience.
Yes.
As a woman. Mm. When I got married, I was in my 20s. I didn't know anything about contraception. I didn't know anything about family planning, which is interesting because I was in medical school. Mm. But, there's a way that it was taught that was more, I'd say, the body, learning how the body functions,
yes.
But really not about when you're now wanting to have a family,
yes.
What can you do? What products are available,
yes.
etc. That was not part of the training of
yes.
doctors at that time.
Yes,
you'd have to come back and get that specialized or advanced information. And nurses also would come back for courses that give them contraceptive technology updates. So,
yes.
For me, I'm talking there for somebody who's educated, and so we went to the obstetrician, and that's now when I began to understand, this method does this method does that, and making a choice. So where I'm going with that is just to repeat what Dr. Serem said. Information is so important. It's not enough to tell me how my body is. Boys and girls really need to understand the menstrual cycle, and to understand that if you choose to have sex in these few days, you can get pregnant. There is something called the cycle beads. I wear them.
I hadn't seen that.
And these enable somebody to count and know their safe days. And then the orange color represents then where you could get pregnant.
Yes.
Because many times what you find when a girl gets pregnant, a teenager, or both the boy and her had no clue that this was in the danger space, and they weren't doing anything about it. So the education, just to your point, needs to be for boys and girls. So when you're thinking about countries, citizens need to demand good information so that they can be making the right decisions.
Yes.
As a parent, I don't want my children to have sex outside marriage. But the reality is, with the way the world is these days, there is freedom of expression, and young people are choosing to have sex before marriage. Or, as you say, in poverty, a girl may be having sex with the border or the guy who's going to buy her the menstrual pads.
Yes.
That girl needs to understand, and that border needs to understand that a pregnancy can happen. Because girls sometimes are told, just swallow a Panadol or something. So education.
Yes.
So citizens need to demand information and very good services, so that when they go there should be a nurse or a clinical officer, a doctor who understands how to talk to young people and not laumu them and chase them away.
Yes.
And then also to serve services.
Yes.
So for FP 2030, when we work with countries, as I said, we're working with a plan, and we are saying, in your country, you already have many donor partners who are helping you.
Yes.
Government is building the buildings, employing the workers, paying the electricity, the water, etc., making sure that the medicines are distributed, and supervising to make sure the services continue. Under the family planning program, however, contraceptives are expensive. So most countries in sub-Saharan Africa are helped by donor partners to buy. So the big thing that countries are needing to think now is donors are moving their interest from purely health to climate and other places. So the government is beginning to look at the plan and say, what's the best way to finance this product, which for a long time we've been getting help?
Yeah.
It's a difficult question for a minister because, or a government. The budget is finite. Even in health, you need to finance cancer, diabetes, you need to finance maternal care. So how do you divide the money out? And so that's why countries are coming up with plans that they're calling the universal health care and defining an essential package of services, which they say every citizen is entitled to. And they'll get this through some form of insurance plan, health insurance. It differs in different countries. And here you bring the private people like your Jubilee insurance, etc. And these services will be offered in private and in public. And right now, our country, Kenya here, is doing that under the SHIF and the SHA, which is the regulatory authority. I tell you, it is repeated the same way, whether we are working in Malawi or Mozambique or Namibia. The countries that don't struggle, the ones that we have formed partnerships with, are like Namibia, because they have minerals. So South Africa, but the rest of the African countries are struggling because you've got debt because of infrastructure. Reality, we know it. We have our expressway, our SDR, etc. Yes. And then, as I said, this budget needs to cover agriculture, education, etc. And then in health, it has to, do you pay salaries, or do you build buildings, or do you buy Panadol, or do you buy what? So as FP 2030, we are sitting with countries and partners and saying, can we get a roadmap for how this financing will go? Because donor funds must decrease. So ministries of health are looking inside their budget and saying, is there any place where there's a saving that could shift? Or is there something coming in from taxes? The HIV program at one time considered taking a tax from the airline tickets, that whenever you pay an airline ticket, maybe 10 shillings could go towards that. So they're innovative. Yeah. So it's that's what we're calling sustainable financing, just recognizing that when you're labeled lower middle income like Kenya, then they expect you to take
Things are changing.
up. But the bottom line, Diana, people need information. You're hearing that me, a doctor, at 26, 7, I was clueless. The other thing, have you noticed when you go to buy medicine, sometimes the pharmacy doesn't give you the full information of all the reactions. So you go home, maybe you've taken something for flu and it's making you very sleepy, but nobody told you it would.
Yes.
So one of the things that Dr. Serem's program does is that they ensure that health workers are trained so that they can tell everybody, if you use this method, you will be protected for this length of time, and then you need to maybe come back for an injection or take the pill or the implant so many years. But these are the side effects you must watch out for. So that way they're removing the myths and misconceptions. People used to think if you put the IUD, which is put inside uterus, your baby will come out holding it, or it will be on the brain.
All those, absolutely.
Yes. So one, informed citizens. Two, citizens should demand services. You saw the other day when there were no vaccines, how mothers came out and said.
Absolutely.
Yeah. So again, women must also demand. But we must also tackle that controversial area of young people are getting pregnant. There's high teenage pregnancy. What are we going to do about that? If I'm a Samburu girl and I'm 14 years old and I'm married, I now live with my husband. Dr. Serem, I can't go to my mother to come and take me to the hospital. It has to be.
You had it here, folks.
You see, because now I have my husband. And my husband wants me to have children because there's the roles that we have as women in society, and we can talk about that. So if I have a bit of information, maybe from my mother-in-law about contraception, when I go to the facility, am I going to be turned away? And I'm married. So that's an area I think that ministry is working on, thinking through. And also, quite honestly, the good thing is that the governors in those counties are so well aware of their population, and they are thinking through those. What Kenya is facing is the same. In Malawi, there's child marriage. Sierra Leone have just passed a law saying no more child marriage. But child marriage is big. Teen pregnancy is huge. It's big time. And we have to think about that and how to prevent it. But when it does happen, how then, after the girl has gone back to school, you know, as a mother and father, you need to have a conversation that is very blunt. Are you intending to continue having sex? We don't want you to have sex. But if you're going to have sex, sweetheart, you have to do something.
Yes.
You know, you have to know that you could get pregnant. And how are we going to stop that? Yes, you could abstain, but what about the one who won't abstain? A difficult conversation. And I speak as a parent. It's difficult. It's difficult.
Absolutely. I really like the approach you've taken. There's an element whereby we have to be real and very pragmatic, right? Because then if this is to work, a large part is, number one, people to demand. And that starts from having the information, right? It cannot be us in our home saying, oh, we've whisked away our girls, they go deliver, and then it's like, it's taboo essentially, right? Yet our cultural practices are such that people do get married sometimes below 18. There are people just because of circumstances, right? And then it becomes, then this is why I think Dr. Serem says it's an option. It becomes, then at that point, you want to have to be able to exercise that freedom, right? And you want, when you show up, because for some of these ladies, and it could even be men at this point, that it is, I only have one chance when I'm in the facility to get that product. If I don't get it that day, the next time I'll be able to swing by here, it's gone, right? So as a parting shot, Dr. Serem, right? And Dr. Macharia, I think we need to have a conversation around gender and cultural norms. We need to have that conversation. But as a parting shot, right, there's already commitment from the government, right? And we need to keep going, right? Dr. Macharia said things are changing. A lot of the support that we are receiving, potentially from a financial perspective, is going to dwindle, right? And it's a transition period. It's not that it's going to end immediately, right? I will ask it as a broad question because I'm not expecting numbers or anything of that sort. Can you say, from the division perspective, there's goodwill to continue the program? You can also see that beyond, say, 2030, 2026, right, whatever the year is, you can see that there's signs that there will be continuity, right? Can you say that as a parting shot, that they will be, so that this number of 54% to 64%, right, will continue because the program is continuing, right? And I'll mention this. I've interacted with the KEMSA program, which is the KEMSA family planning program, right? The integrated system, right? Which is one of the best I've seen, digital health commodities program I've seen. So I'm coming from a point where I actually have seen that commitment from partners supporting us, but also from a government perspective, there's commitment to the family program. Is that going to be the case? Are we going to, these numbers, are they going to go on or, yeah.
Thank you. Yeah, thank you very much. And with your question, I would like to tell you that, of course, we are very optimistic. And this one comes with the funding. And first of all, to reiterate my statement is to mention that family planning is voluntary.
Yes.
Okay, we are not imposing this one to anybody.
Okay.
If you opt to have 2 children or 10 children, provided you can take care of them. That is our policy. Point number 2 is, of course, Kenya is committed to FP 2030. What Dr. Sheila is pursuing. I mean, we have both, and it has. I mean, there are 8 commitments there.
Yes.
Making sure that we move from 57 to 64, making sure that we train the counties, making sure that the commodities are availed, making sure that we reduce the unmet need, and very many other things.
Yes.
So therefore, with this, of course, it requires sustainable financing.
Yes.
That is where the rubber meets the road. All right? Because all these things you require finances. And I want to categorically state that, and I want to thank the partners because we have been in partnership and collaboration in making sure that we avail these commodities for the Kenyan population. Of course, the donor funding is dwindling, it's going down. Yes, but of course, with the Social Health Authority and the Social Health Insurance Fund,
Yes.
Primary Health Care Fund is indeed an exchequer, and it's going to meet the expenses in level 2 and level 3, where most of the majority of the population are.
Okay.
And indeed, family planning commodities is part of the benefit
Essential.
package.
Okay.
Yes. So with this, therefore, as part of therefore moving forward is looking at domestic financing.
Yes.
Sustainable. And we are talking about domestic. Are we in a position? And taking the way of the insurance.
Yes.
Taking the way of the insurance. Just the way the president has taken. That we need to actualize social health authority and social health insurance. Then is the way to go forward. As a low middle income country.
Yes.
Yes, I know
Yeah.
we have a lot of things for 2030.
Yes.
But I also believe economically,
Yeah.
Kenya should be upper
Yeah.
middle income country
Upper
by
middle income.
by 2030.
Dr. Serem.
Yes. So, and yes, I mean I have that aspiration. Yes, because as a country, and also to make on that, also to point out on the issues of providing information to women and girls, and also men, because men also contribute heavily
Big alliance.
to issues of family planning, because it is not a woman or a man's decision. It has to be, it has to be mutual.
Absolutely.
Therefore, we are developing what we call parental guide.
Yes.
And parental guide is we want to also assist. We come with the guidelines to help parents, because parents don't know how to counsel their children, and even to counsel themselves. And therefore, we are coming up with that guide to be in a position to counsel the adolescents and to give the correct information. As part of the information you're saying, we want to give information as understanding. I mean, when the breast starts developing, when the hair starts now, coming from other areas, I mean, the individual has to understand that this is, I'm expecting this, and this is going to happen. Thank you very much.
I tell you, Dr. Serem, it is not an easy job you have. From information to counseling the parents, then the parents have to. It's not. It's good that the commitment is there, because a lot of these things, sometimes you need that goodwill, right? And you need to take a very comprehensive approach, starting from, as you're saying, information to assuring us that, under SHIFSHA and the rest, it is a benefit. So someone who's out in Lodwar will know that they can still have that access and it will be covered. I think that's important. You must invite us so that we see some of these initiatives. You really must. Dr. Macharia?
Yes.
We have another conversation on gender. Cultural norms. We have to.
Yes,
we have to. But Dr. Serem, thank you so much. Dr. Macharia, thank you so much for joining us. And we'll keep having these conversations. Asante.
Thank you
very much. Feel free to call us anytime.
I am going to be on the door and say I want to see how far have we gone.
Yes.
Thank you so much for joining the One Health Lens podcast. We'll see you next time.